Hi, wonderful students. This is the chapter on documenting and reporting. Here are the learning objectives for this chapter. Please take a moment to review each one of these. What are the guidelines nurses should follow when documenting? Your textbook has some really great information in there, so I'd like you at some point to pause the video and go in there and actually look at it and review it and follow along with me as we go through this. So first of all, your content has to be complete, accurate, concise, current, and just the facts. No personal opinions or stereotyping. It should reflect the nursing process. Avoid vague terms like good or average, as they are not descriptive enough. You should avoid generalizations also. Note problems in an orderly sequence. Document all precautions or preventative measures that you have took. Document as you go along during the day. Do not wait to document until the end of the day at the end of your shift, because many times other healthcare team members are waiting and utilizing the most current information to do tests and order meds and all kinds of things. So it needs to be accurate and up to date at all times. Always include a date and time using military time. Never ever document interventions before carrying them out. This is falsifying the record. Document all progress, procedures, communications, and for any change in patient status. Make sure you are in the correct patient record using standardized, acceptable language and approved abbreviations and symbols only. Your book has the Joint Commission's official do not use list. Make sure you review that and know it, as it will be on your test, and it will also be in HESI and on the state boards as well. Pause and take a moment to get to know those, okay? Make flashcards, however you get that information in your long-term memory. Follow the agency's policies for formatting. Make sure you have an electronic signature on every entry. Recognize that this patient record is a permanent record. If it is a paper record, make sure to use black ink only. And if you make a mistake, you're going to put a single line through it, write mistaken entry, and then initial it. Follow agency policies for mistaken or late entries for electronic health records. Patients have a right to have their information remain confidential, with only people authorized to access the record doing so. So it literally is on the basis of the following. If it is a need to know to care for the patient, then the person has a right to know that information, the healthcare employee. If that person is not part of that patient's care team, then they do not have a need to know, and therefore we should not be sharing it with them. Students can access multiple records if it is for learning purposes only and it remains confidential. Never remove records from the agency, and never identify a patient by their name or state their age if they are over 89 when doing care plans, because we can't dispose of this information, okay? There are parts of the medical record that are always kept confidential. They are listed here. Pause the video again and make flashcards and note cards so you can commit this information to your long-term memory. There are several ways that confidentiality rules can be accidentally broken. They are listed on this slide. Again, please pause the video and make flashcards of this because it's important to know it. The medical record is the property of the healthcare facility, but a patient can request a copy at any time. This is usually a written request, and the physician should be notified by the patient making the physician should be notified that a patient is making that request and which one. Your book has tips for preventing breaches in patient confidentiality. I would recommend you pause the video and go look at those, and again, make sure you understand them. How do we utilize the written or electronic record? We use it to plan and evaluate patient care over time. We use it to communicate patient status and care between the different disciplines. You as students will utilize it to learn from. You need to remember that the patient's record is a legal document. The record can be subpoenaed to be presented in a court of law. Usually lawsuits take several years to come to trial, so you must document adequately so that if you have to defend your charting years later in court, you can easily recall that patient and situation. Never guess what a handwritten order says. You'll call the provider and have them confirm what their original order is. Remember, as a student nurse, you are unable to accept any verbal or telephone orders. Healthcare agencies will audit records to see if the patient outcomes are good and decide on any areas for improvement. Accrediting agencies will review records to ensure the delivery of quality care and protect public safety. Nurses are obligated to include documentation regarding the professional standards of care. Records are used in research to review interventions and outcomes. Insurance companies may use the record to determine agency payment. Also, they will do a utilization review to determine if the medical treatments and interventions that we utilized were appropriate and necessary at the time. Patient records include diagnostic and therapeutic orders. Verbal orders are usually only accepted and will be given and taken daily in the hospital and agencies across the nation. So again, verbal orders by doctors to nurses are legitimate orders and are taken all the time, right, in the facilities. Now, what I do want to say is, if you get a verbal order from a physician, it is mandatory that you read that verbal order back to the physician to ensure that that you heard it correctly, right? And please make sure they actually give you a verbal yes, that is what the order is, just to confirm it, okay? Make sure again to read back that order in its entirety and get a verbal confirmation that you are correct. Spell out anything unfamiliar or ask for spelling of medications that you are unfamiliar with. Pronounce digits of numbers separately. 15 and 50 sound very similar. Have the patient's EHR open to the order screen or have a paper order sheet ready to write on. Enter the date, time, the order, then write the big T dot big O dot for telephone order, the prescriber's name, and then your name and title. The physician is required to come in and sign off on the order within 24 hours of receiving the order, or they just log in electronically and sign it. But it has to be signed within 24 hours of the order being given. This slide reviews the benefits of electronic health records. Electronic health records have many advantages, but also a few disadvantages. Multiple healthcare providers can access patient information at the same time and even remotely. Nurses can spend up to 25% less time documenting. Information is quick and easy and can be retrieved really quickly. The system can automatically enter protocols and standards of care, standard orders to keep our patients safe. They can have programmed alerts built into the EHR system. Data is available immediately to make patient care decisions. Information is permanently stored and unlikely to be lost, like paper. Information is safely stored unless people entering the system do not safeguard the record and lock the screen when they walk away, right? Some disadvantages of the EHR systems are they are expensive. They're expensive to keep for the upkeep, and sometimes there is unexpected downtime, right? Also, some of the systems are not user-friendly, and some require redundant information to be entered time and time again. And lastly, the information may not be integrated across all the different systems and departments and companies that work, right? We all use different systems, basically. These are the guidelines for safeguarding your patient's confidential health records. Please pause the video and get to know these. Many people are now creating online personal health records to help manage their health care via the computer source, right? These can be shared with the appropriate healthcare providers if they are given access. There are two different types of these records. One is a standalone record where the patient fills in the information from their own records and it is stored on their computers or on the internet. The other one is a tethered or connected personal health record. These links to specific healthcare organizational EHRs. Patients can access their own health record through a secured portal. They should check the service's privacy policy carefully to see how much control they actually have over their information within those tethered, connected personal health records. And Honor Health has a tethered, connected personal record called MyChart. That's what it's referring to when the patients can look up their chart within the Honor Health Epic system. Health Information Exchange, or HIE, allows healthcare providers and patients to share the patient's vital medical information. The benefits of a system like this is listed on this slide. They have found that it improves quality and safety of care, it stimulates consumer education, it creates a loop for feedback, and it facilitates emerging technologies. So it's really helpful. There are different types of records out there. Source-oriented record systems are used in hospitals and long-term care facilities. Source-oriented records, they record each discipline's records. Their findings are in different separate sections. And they're usually broken up by categories. Some of these may include like admission data, history and physical, physician's orders, and then the physician's progress notes, and maybe nurse's notes, and then diagnostic studies and flow sheets, therapy notes, et cetera, et cetera, et cetera, right? You can easily find what discipline is doing by going to that piece of it, that record of it, right? But then again, it may be fragmented and scattered throughout the record too, right? When working on a specific patient problem, you have to look through each discipline notes to see the interventions and outcomes for that specific problem. In a problem-oriented record system, there are no separate sections for each discipline. The charting is organized around specific patient problems. It has 4 parts. The database has many parts to it as well. They contain demographics, history and physical, nursing assessment, and psychosocial history. The problem list is gathered from the data in the database. The plan of care includes orders, nursing care plan, and other discipline interventions. The progress notes are organized according to the problem list. Everyone charts under the specific problem they are working on. And this is a nice system because it's centered on the patient and the resolution of the patient's problems, right? And you can easily see all the disciplines' progress notes and what they're working on within the problem itself. So that's why I really like it. Next is problem intervention and evaluation, or what we call pie charting. And pie charting organizes information according to the patient's problems and requires a daily assessment record as well as daily progress notes. Problems are identified from the admission assessment. First, you identify which problem you are addressing. Then you document the nursing interventions you completed. And then lastly, you document your evaluation of the patient post-interventions. A drawback to this form of charting is that you only focus on the patient's problems and not the patient as a whole, right? You're not looking at the patient holistically. And there is no planning portion of the nursing process in the documentation, so that's not good too. SOAP charting is next. SOAP charting stands for Subjective, Objective, Assessment, and Plan. And then you'll hear about SOAPIER, S-O-A-P-I-E-R, and that's where we add the interventions and the evaluations and the revision as part of it. Next is focus charting. Tries to view the patient from a positive angle instead of a negative angle. The focus is identified usually as a nursing diagnosis. It incorporates DAR charting also, which stands for Data Action Response. And this addresses the patient holistically. Data is the subjective and objective information that we collect, the nurse. Action is what is done about it. And response is the patient's response to the action or intervention that the nurse completed. There's an example of this in your textbook. Take a moment and read through it. It's really good. An example of this charting is on this slide. In charting by exception, you only document significant findings or exceptions to standards and norms. It uses pre-printed or standardized computer screen flow sheets to document most aspects of normal patient care. Charting by exception assumes that all standards have been met and that the patient has responded normally unless a separate entry is made by the nurse, right? This reduces the time that is spent on charting, so it's extremely quick, right? So charting by exception is liked by many for-profit organizations, again, because it's quick, and therefore they can move from patient to patient rather quickly, documenting, right? So again, it reduces the amount of time spent on charting, and the record is easy to read, and it does highlight any exceptions. But can you see a flaw in this system? If someone were to get lazy, or even not get lazy, but forget to document an exception, that could be really, really bad, right? What does the charting really tell you? Is it complete enough to protect you in a court of law? That should always be what's in the back of your head when you're charting, right? So when I work for companies who have charting by exception, I typically will chart almost everything as an exception, okay? So some of the questions you need to think about, right? All right, next one is case management model promotes collaboration, communication, and teamwork among the caregivers. It uses collaborative pathways. The pathway specifies a plan of care that has specific interventions with expected outcomes along a specific timeline. Again, I have an example of this on the slide. Okay, so looking at this, all of these as a whole for methods of documentation, charting by exception is frequently used with collaborative pathways. When a patient fails to meet an expected outcome or a planned intervention is not done, this would require an occurrence or variance documentation. You would document the unexpected event, the actions you took, the patient's response to the event and your interventions, and then of course come up with a discharge planning. There are different formats for nursing documentation. An initial nursing assessment contains the nursing history and physical assessment. There is an example of one of these on this slide. The nursing plan of care can be written separately or incorporated into a multidisciplinary plan. Patient care summary is an overview of important information like lab values, orders, medications, all of that. Progress notes are just what they sound like. They review the progress the patient is making towards achieving their goal. Flow sheets contain the routine aspects of care being provided. Graphic records contain patient variables like vital signs, weight, eyes and O's, bowel movements, all of that kind of stuff. Medication administration record, or MARS, have all of the medications that have been ordered for the patient, including scheduled, PRN, as needed, stat, all of that, right? And the nurse documents, when we give the medication in the MAR. There are regularly scheduled meds again. We have unscheduled or PRN meds. We have continuous infusions, PRN infusions, single order meds where we give it at a specific time once. Injections require you document where you gave the injection. Some medications like DIG requires an assessment of some parameter. For example, DIG, apical pulse for 60 seconds. And you've got to do that prior to giving the med, right? This information, again, will be documented in the MAR. Drug allergies are also listed in the MAR. For PRN, stat, on-call, or single order meds, please make sure that you document the exact time you gave it, the patient's response to the medication. If a medication is not given, you will need to do an additional documentation and explain why you held that medication. Acuity records are where nurses rank their patients from high to low based on the patient's condition and their care needs. A discharge summary is the last entry in the chart. It should be completed when a patient is transferred internally or to another facility or they're discharged home. This may be an multidisciplinary form. Forms are different for every organization. A discharge summary must contain several elements and is very comprehensive. You need to summarize the reason for the patient seeking treatment, significant findings, the procedures performed, treatments given, any teachings you've provided or any handouts you've given, the patient's condition at discharge, how did they leave, and who were they with, right? It takes time to complete discharge summaries, right? But they're very, very important and as important as all other documentation. Remember, if it was not documented, it was not done. Home health care documentation report the initial assessment using an outcome and assessment form set for the OASIS system. These forms the basis for care and projected outcomes. They include socio-demographic environments, patient support systems, the patient's health status, as well as the patient's functional status. The nurse also completes a progress note with every one of their visits. The information needs to be included in the patient's homebound status, the patient's physical condition, the care the nurse provided, and the patient's response to the care the nurse provided, and also the need for continuing care, or if they don't need continuing care, we can do a discharge plan. Long-term documentation is specified by the Resident Assessment Instrument, or RAI. This helps staff get information on a resident's strengths, a resident's needs, and addresses these in an individualized plan of care. It has 4 components to it. The minimum data set, which has the assessment, clinical, and functional status of the resident. It identifies residents at risk for developing problems and requires further evaluation. It provides an organized framework for resident care, and it directs staff when and how to use RAI. RAIs must be completed on a resident who will reside in the facility for longer than 2 weeks or 14 days. Benefits of RAI include providing individualized care, improved staff communication, improved involvement in care by the patient and the family, and clear documentation. SBAR or ISBAR is utilized in nursing care when giving handoff report or when communicating with providers. You start out with who you are and where you are calling from, then what is occurring with the patient, any pertinent background information, your impression of what is going on or changing with your patient, and then what you would want to do about it. You were all given an example of this process on the form handed out earlier in clinical and lab. A handoff report is also called a change of shift report. This is done to make sure the next caregiver knows the patient's status, any changes in condition, plan patient activities, tests, labs, procedures, current orders, abnormal occurrences during your shift, any unfilled orders, if the patient has restrictions, concerns about, any kind of concerns, and then any questions that they may have. This also helps the nurse prioritize patient care and plan the day's priority nursing actions. Usually this is done verbally and face-to-face, and usually at the bedside. This tends to be done at the bedside so that the patient can be part of that handoff report. Telephone and telemedicine reports can link healthcare professionals immediately and can give nurses critical patient information in a very timely manner. The process of completing a telephone or telemedicine report is listed on this slide. Please pause the video and make note of them. Incidents or occurrence reports are a record of an unexpected occurrence. A near miss is when something almost went wrong, but someone caught it before it happened. These are not part of the patient's record. These are completed and are stored and tracked by the agency, and it is specifically the agency's risk management department. These reports are used to track problems, identify areas for improvement, areas of improvement of systems or procedures or buildings design, maybe communication patterns, policies, all of these things that may need to be improved. You need to report and record all errors, even if there was not a negative outcome. When completing an incident report, you need to identify the patient or person in the incident, the date and time, and the place of the incident. You're going to describe what you observed or saw. Again, just the facts. Make sure to include only the facts. Don't include any inferences, assumptions, any of that, right? Quote the patient if necessary. Do not draw a conclusion or point blame. You will document the incident. Again, do not document that there was an incident report filled out, but if a patient does have an incident, for example, if they slip out of bed, you will document this incident in the patient's chart too, but you will not mention that you filled out an internal incident report, okay? And the final slide, nurses also may need to consult with someone for ideas or seek information or advice or instructions. This can include consultation by inviting another professional to evaluate the patient and make recommendations, or obtain a referral from another source for assistance. Determine which professional is needed for their expertise in any given situation and follow your agency guidelines when a referral can be done by the nurse, or do you need to get an order from a provider, right? Sometimes the nurses conduct care conferences for plans and coordinating patient care. Everyone gives their perspective on the patient situation and possible solutions are suggested. Nursing care rounds have a group of nurses selected and they visit the patient individually at the patient's bedside. The nurse provides a short summary of the patient's nursing diagnoses and the goals of care being given. You can see the patient as report is given, and the patient and family can participate in these discussions. You had an example of this in the video in clinical lab earlier in this semester. If you don't remember this, go back and review it. All right, this is the end of documenting and recording.